But really quickly, just introducing Dr. Weiner. He's currently the Chief of Urology for NYC Health and Hospitals. He's also the Director of Robotic Surgery for that site, as well as an Associate Program Director for Urology and Associate Professor at the SUNY Downstate of Medicine. But I always like to say, and he knows I always finish it off, the most important thing is he's a practicing provider, right? He's treating patients and seeing patients on a daily basis, just like all of you. And really that clinical aspect is really what we want to try to, tease out of him tonight. So feel free to ask him any questions. And with that, Dr. Weiner, I'm going to pass it right on over to you.
So I want to go into a couple of real world examples, if that's okay. And again, these are my patients. So I'm kind of proud to present these to you. They're not perfect. These are real world in my practice patients. And so, at the end, I'd love to go back and forth about these and how you maybe would have treated them. But I'd like to share a couple examples of how I've used GPS to help me navigate this space. So in this patient, it was a 64-year-old gentleman, African American with a PSA of 6.3, clinical T1C with an MRI PIRADS 3 lesion on the right side, as you can see here. You could make the argument maybe PIRADS 4, it's a little bit large, but my radiologist called this as PIRADS 3. So we did a 12-core sampling and we got grade 2 in 2 out of the 12 cores. And in my practice, 2 cores of favorable intermediate risk disease, we're having a conversation about active surveillance. It may not be what we ultimately do, but it's part of the conversation. So I got a GPS test on this patient, as I do for all of my active surveillance patients, and it came back as a GPS of 38. So let's just pause here for a second and take a look at what the report looks like and what you're going to be handing this patient and their family. So you're going to get a number, a GPS score on a bell curve. And on this first page, the GPS score is agnostic of any clinical parameters. And it takes into account just the genes, the 12 oncogenes and the 5 housekeeping genes that I mentioned. And it comes out with a score, a GPS score on a bell curve here. And you have the median right here at 28. And I mentioned in Vip Patel's study, they found that 29 was sort of their cutoff. So somewhere between 28 and 29 is where we're looking. And then you have a really nice color-coded, low likelihood of adverse pathology at the time of radical prostatectomy, less than 25%, moderate likelihood, 26 to 59%, and high likelihood, greater than 60%, again, of having adverse pathology of T3A and higher at the time of prostatectomy. I print this out. I sit with the patient and their family, show this to them, help them understand what this means. Okay, and then on the second page, takes into account some of the clinical parameters like PSA and the Gleason score. And you can see here, it comes up with another percentage of high-grade disease and non-organ confined disease, or T3A disease and higher, as well as their risk of METs and prostate cancer death at 10 years. So you can see in my patient here, this patient had 28% chance of having greater than grade group 3, Gleason 4+3, and 34% of non-organ confined disease. So at 64 and otherwise healthy, this gentleman, I recommended intervention. He underwent a radical prostatectomy, and you can see here he had negative nodes, but he had grade group 3 disease in 30% of the prostate with negative margins, thankfully, and it was a PT2 and 0 disease. So this patient, I think that we did him a service by catching that early. Another example number 2, this is a 76-year-old African-American male with a PSA of 7, again, clinical stage T1C. Now, this is a gentleman, he comes to me at 76 with a PSA of 7. I'm wondering why he got a PSA to begin with, but patients are living longer and they're still getting PSAs. So this is a person that in the back of my mind, I'm saying, I don't really want to biopsy him if I don't have to. So here, we first employed the use of select MDX. So I got a select, and what the select showed me is that he did indeed have a 25% chance of detecting Gleason grade group 7 and higher, and a 53% of any sort of prostate cancer. So for me, this is a patient that I would have liked to have not biopsied, but this pre-biopsy genomic biomarker helped me realize that I should actually biopsy this patient. So he underwent a biopsy. He went to MRI first, and he had a PIRADS 4 lesion on the left side there. And you can see here, that's a decent, a hypoechoic lesion over there. So I was fairly worried about it. And then it came back as grade group 1 in 2 out of 12 cores. So there's some incongruency here, right? You have a PIRADS 4 lesion and then grade group 1 in 2 out of 12 cores. So this is a patient that I ran a GPS on. And the reason I like to highlight this is because it came back almost identical. If you look at the parameters here, it was almost identical to that last patient. A GPS of 38, 48% chance of having adverse pathology at the time of prostatectomy, 28% of chance of high-grade disease, and 34% chance of non-organ confined disease. So this is a gentleman, again, that I would recommend intervention on, but he really, really persuaded me. He was adamant about continuing on active surveillance. So, but we agreed, we made a pact that we would do at least a restaging biopsy at 6 months. And what we found is that we repeated the MRI first, again, of PIRADS 4 lesion. His PSA rose from 7 to 13 in 4 months, and we ended up doing the biopsy with some saturation in that particular area. And he ended up having grade group 4 in 3 out of 14 cores. This gentleman underwent radiation plus 2 years of hormonal therapy. So again, not every one of these tests is going to be accurate, but these tests I'm showing you, and obviously they're cherry picked. I'm showing a big group of urologists and physician extenders and the like. And obviously these are biased, right? Because I chose them, but there are many more in my practice that I've used and with the same exact results here. So this really helped, I think, save this guy a lot of headache later on and potentially, a very bad outcome. So we're going to kind of quickly move through a couple of other examples here. This was a 67-year-old African-American, generally healthy, hypertension, glaucoma, BPH, but a PSA that rose from 4.5 to 7 in the span of 7 months. So he underwent an MRI, and you can see here, nothing too significant, maybe PIRADS 3 on that left side, but nothing too concerning. So he underwent a prostate biopsy, and if you look here, he had 4 cores of grade group 1 disease. So if I was with you guys in the audience, I'd love, to poll, and maybe we can come back to this example after I'm done talking. I would hope that this is a patient that we're at baseline really strongly considering active surveillance at its core. So like this one, for me, knee-jerk reflex should be active surveillance. But I don't start my active surveillance protocol until I have a biomarker that convinces me that biologically this thing is what it says it is on pathology. And I have excellent pathologists. So this isn't, a flaw in the pathology read. This is just the limitation, I think, of what just a standard pathology does. And this augments what the pathologic read is. And as you can see here, before starting active surveillance, this patient had a GPS score, and he had a GPS of 40. So again, I'm not going to go through all the other parameters, but this was a trigger for me. Hey, Dr. Weiner, we got to do something. We cannot sit on this patient. Okay, he's otherwise healthy, and we could lose this guy if we don't intervene. So he underwent a prostatectomy, and he had focal extraprostatic extension. So he did, in fact, have T3A disease, fortunately no nodes, and negative margins. Now he's still early on in the follow-up, but hopefully he's going to be one of the 70% that I mentioned that can enjoy having, disease-free status for the rest of his life and no recurrence. So we have a 67-year-old Caucasian male in this next case, a fairly large prostate, but hard to examine based on his body habitus, otherwise pretty healthy, and a smoldering PSA in the 5s. Undergoes an MRI as somewhat of a screening tool in addition to a biopsy. that we performed, but there's really nothing to target here because his PIRADS score was 3 and 2, and his prostate wasn't, overwhelmingly concerning based on the MRI. But he underwent a biopsy and we found grade group 2 in one core and a focus of ASAP in another core. So again, this is the limitation of our MRI in 2024. And some may argue that they're a radiologist or they can read better than I can, or that MRI does a better job. But in my opinion, there are major limitations to MRI, up to 20-25% that are miss significant prostate cancer. And this is one of those cases. Focus of grade group 2 that would have been missed. So in this case, again, low volume, favorable intermediate risk, pretty healthy person. I'm trying to leave this guy intact because even in the best of hands, we're still decreasing their erectile function and making them go through a couple months of, or weeks to months of incontinence. So if they can avoid it, I think that's the way to go. But I employed the GPS test here, and you can see here, this is one of the higher scores that I've seen. One core of grade group 2 and a focus of ASAP and a PIRADS 3 on MRI. This gentleman had a GPS of 51. So he's got 63% chance of adverse pathology at the time of prostatectomy and up to 50% non-organ confined disease with 6% chance of METs within 10 years. How can you argue against this? I mean, it's like, for me, this gives me chills. Like, you would have potentially lost this patient if you sat on this guy for 6, 12, 18 months before you did your next biopsy. So he had to travel. So I gave him a short course of Lupron, and then he ended up coming back and we did his prostatectomy at that time. And still at the time, even after hormonal therapy, he still had 50% pattern 4 in his total tumor volume, which probably shrunk and also was downsized. So, fortunately, again, good outcome for him so far. But again, this is one of those patients that I fear would have been lost if we had pursued active surveillance. And going back to our active surveillance cohorts, this may be the reason why you're seeing between 1 and 6% METs and death in long-term follow-up for active surveillance. So just a couple others. So we have a 52-year-old gentleman here, pretty healthy guy. PSA goes from 5 to 8 in 2 years. PIRADS 4 lesion on his MRI. Hard to see here in this cut here, but my radiologist called it as a PIRADS 4. And he underwent a prostate biopsy that found 2 out of 12 cores of grade group 1. When I employed the GPS, it was a 28. And fortunately for this gentleman, this is where I'm going to sit and have a long conversation about the risks and benefits. But he's a really good candidate, in my opinion, for active surveillance with close follow-up. So again, kind of hovering on that border, 28, 29, but he's willing to take that risk, and so am I, because I think biologically it mirrors what we're seeing on the biopsy. And then moving into two other cases here. So these are other patients that I've had. So a prostate volume of 40 with a PSA density of 0.13. So I'm using a lot of PSA density as well. I think it's very helpful. But this patient underwent MRI and focused the MRI biopsy on a couple of areas. And what you found here is 2 out of 16 cores had grade group 1. And the GPS confirmed what we're seeing here, GPS of 22 with 11% chance of adverse pathology. So again, what we're seeing in my hands, in my practice, is a test that is successful in identifying patients that we can watch versus those that need intervention. And so the prostatectomies that I showed you, those are ones that needed to undergo surgery or radiation. And these are gentlemen that I think are safe to watch. Whereas, Decipher, that 60% getting upgraded, that is a massively high number, in my opinion. And then the last one here, kind of confirming what I said before, this PSA density was 0.23, which is above the 0.15%, 0.15 cutoff that I use. And he had grade group 1 in 2 out of 12 cores with another confirmation here on the GPS. So he is 100% going on active surveillance in my practice.